Hi again, everybody. Thank you so much for being here this afternoon and watching all of these great presentations. And now we are live, so we have real live people. This part's not pre-recorded. We have a kitty cat representing because, again, it's Halloween. So welcome to the live Q&A portion. We have a great panel of speakers who you all just heard from. Before I dive into questions that I've been collecting from you all, I do want to say I should have noted during the opening remarks, and it kind of goes without saying, but I just have to say it. I want to note that the information that was shared during the presentations and during this panel discussion, not meant to be medical advice. So just keeping that in mind. The question I would like to start with, and I think any of you, all three of you, could really address this. We got a few questions in the chat and also during registration about excessive saliva and drooling. So people wanting to know, is that related to swallowing at all? What are options to treat and manage it? One person in particular said that his wife has this challenge and they go through 2 boxes of tissues a day to wipe away the drool. Another person mentioned that their father has constant drooling despite glycopyrrolate 3 times a day. So maybe starting with Dr. Brandimore or Dr. McFarland, if you want to speak to saliva and drooling, that'd be great.
Sure.
So Dr. McFarland, do you want to start and then I'll follow you?
Yeah, sure. I can start. I mean, so drooling is a big deal in all the Parkinson disorders, particularly PSP. So, it starts out sort of a little bit and then can gradually progress to, needing, constant hanky or a bib actually needed for the drooling. And there are lots of different ways that we treat it. So it's either excessive saliva production and may also include sort of difficulty with swallowing. So there's just more saliva that's pooling basically in the mouth and the throat. So, both can contribute to it. Likewise, sometimes people have their mouth open a lot, so it may kind of just drool out of their mouth. Of course, having an open mouth all the time also can lead to dry mouth too. So we do treat it in lots of different ways. One is just wiping it. But medications there's a number of different ones that are out there. Most of them are what we call, they have anticholinergic properties. So the problem with that is, can cause some confusion. So what they do is these medications essentially just dry out the saliva production and can make it thicker. Okay. Also harder to swallow too. So there's a give and take in it. Glycopyrrolate is one of those medications that we prescribe sometimes for drooling. It's a 3 times a day drug. But there are lots of other options that are out there. Levsin, the patch, which is called scopolamine, although that's something you put on that lasts for 3 days. And again, if you have confusion issues, that is probably something I don't usually recommend. Lastly, if for at least drug-wise, you can use drops. We call them atropine drops. They're for the eye. So if you've ever had an eye exam where they dilate your eyes, it's the exact same thing, except for you take the eye drops and you put them underneath the tongue. And that can be used as needed, like 1 or 2 drops every so often. I do think, as a physician, I think of those as being more sort of for more advanced patients who are being cared for by a caregiver. But they certainly can be used by anybody. They just really dry out the mouth. So confusion, dizziness, excessive dry mouth can be complications of these medications. Also because they have effects on the nervous system and things like control heart rate. If you really overdose, you can slow the heart rate. So that's another risk factor. So, I think it's important to talk to our, speech pathologist here too about the effects of these medicine on swallowing and complications thereof too. I turn to you.
Yeah,
Alex.
thank you. Again, forgive the face, but happy Halloween. So this is a question I actually get a lot. And part of it is related to the fact that because you have a Parkinsonism, your brain is spending a lot of its time focusing on just daily functions and taking care of itself. And so our attentional resources to swallowing kind of decreases. So you don't swallow as often during the day. And because of that, you kind of you're not thinking about swallowing, so you aren't managing the saliva as effectively as if you were kind of responding to the stimuli normally. So an easy way to kind of combat that, just things I have my patients do, is carry around, these handy dandy, any size sort of portable cup. Having the water around reminds you to swallow, so you swallow to manage it. It also can be your body's way, that, kind of that excessive drooling of telling you, hey, I need some water. You might be a little bit dehydrated as well. And so it's kind of killing two birds with one stone, keeping you adequately hydrated, but also reminding you to swallow so that you manage the saliva a little bit more comprehensively. So those are kind of just two of the easy fixes just with drinking water. I've had patients say that they like to chew gum. I've had patients receive Botox for excess saliva in actually a different patient population, but I don't know if it would be appropriate here too. So there are lots of different things like that. The gum, again, is just reminding you to swallow. So those would be my kind of tangible recommendations, but I know it's burdensome. In one severe case, I will say I've had a patient wear a mask, just like we did during COVID, and have gauze inside. And so it just sort of collected the drool in a way that made them feel more discreet about it. So just little fixes, but it's definitely a challenge.
Hey, Alex, I want to ask you, how do you feel about suction?
How do I feel about suction?
Yeah. This comes up a lot too
for
folks who got a lot of drooling too. So,
I think I don't have a problem with suction. My bias is always going to be on trying to rehab it or fix the problem, kind of like, as opposed to just treating it with the suction. I would rather have you pay more attention to your swallow more frequently, do some exercises with a speech pathologist, like an effortful swallow, to help, really stimulate those muscles a little bit more. But yeah, I've got no issue with suction. I think if it works for you, you got to do what is easiest for you, honestly.
Yeah. Cool. Great.
I tend to see success with suctioning when it's the more thicker secretions that people can have, and that's sort of what they're choking on a little or aspirating on a little bit. And I especially have seen that with more MSA rather than.
And I will say a wet washcloth does wonders too, to kind of collect those that dry up in the morning after a night exposed to air. A wet washcloth can kind of sometimes be your best friend. Wake up the oral cavity, clean it out, move on.
Yeah, I would agree with all that. Bring up suction. It comes up a lot. People ask a bunch of questions in all of these diseases. And it is hard with the really thick secretions. The suction gets gummed up and it can be hard. So really kind of hydrating. I totally agree with you. If they're thicker, you need to hydrate more, and then you can probably get the suction up. But suction can be useful for some patients, but you have to have the hookup and the setup for it. And it needs an order to get it, so you can buy them and get some coverage for it in Medicare. So
starting out with trying to thin the secretions is like the first step.
Yeah,
makes sense. Okay, moving into my next question, which is for Matt. Someone had asked this during registration, which is, are there any nutritional supplements that you could recommend?
Sure. Great question. So I get this question a lot as well. I am someone who started my career working in a supplement store. So I've seen everything. This was before I became a dietitian. After being a researcher for a number of years now and getting all the degrees that I have, really, I tell all my patients, keep it simple. You don't need to get fancy with it. I recommend a very small number of supplements. One of the most common that I recommend is a multivitamin, a full spectrum multivitamin from a brand that you recognize, One A Day, Centrum, Solgar, something that you can take most days or all days of the week easily. If you have trouble swallowing big tablets, those are the ones that you can't pull apart. Go for the capsules. The capsules, you can pull them apart, put them in a beverage, maybe take them that way. What I will say about multivitamins is, if you can, avoid the gummy multivitamins. The reason being is there is such a small amount of vitamins and minerals in there. It's almost not worth taking, in my opinion. Maybe if you really need to I don't know, try to correct some deficiency, but a gummy multivitamin isn't going to be the way to do that. So multivitamins most days of the week, that's what I recommend. For specific people, a protein powder or the nutrition supplements that you saw in the presentation earlier, like an Ensure or a Boost, can be a great way to get some very easy calories and or protein. Obviously, unintentional weight loss is definitely a possible symptom of these diseases and disorders. And so we want to make it as easy and convenient as possible. And so if eating a large meal is something that's not feasible or takes too much energy, being able to grab one of those out of the fridge, crack it open, and drink that at your leisure is definitely a convenient and easy way to get some great nutrition.
Also, I take gummy multivitamins and now I won't anymore. So thanks for taking away my dessert after dinner, Matt.
I'm so sorry.
It's like my dessert. Okay, so super helpful. Thank you. And then kind of going off of that, a question for you, Dr. McFarland, that somebody asked. In your presentation, you talked about CoQ10 for PSP. Can you talk a little bit more about that? And is there like a specific dose that is recommended for people to take?
Yeah, so CoQ10's been studied in a lot of our neurodegenerative diseases, from Parkinson's to Alzheimer's and all of these Parkinson disorder, atypical Parkinson disorders. So each one's a little bit different. So for PSP, there's only actually been 2 studies that have been published really on CoQ10. One was very small, one was larger, and they both showed a trend. A trend means it wasn't really significant. And both of those required a high dose. So the theme of the day is high dose CoQ10. So what most people take over the counter is just 100 milligrams, which usually is a supplement for heart. That's not enough. We're talking for oral CoQ10, it's poorly absorbed. So we're talking 1,200 milligrams a day. So that's a lot, 1,200 milligrams. And you can divide it up. It's not easy to find pills that big. So 400 to 600 milligram tablets or capsules can be found online. Usually I go to show people go to Amazon, but that's a good place to find that. If you have difficulty swallowing pills, I recommend the liquids. In fact, the liquid CoQ10, or what's called ubiquinol, is a little better absorbed. You can take the same amount. One of the studies actually used what's called liposomal CoQ10. It's just a form of liquid CoQ10 that is much better absorbed. And the dose, if you can find liposomal CoQ10, the dose for that is 300 milligrams a day. So that was for PSP specifically. Now, there are no great studies in multiple system atrophy CoQ10 and haven't really shown any major benefits. Cortical basal degeneration likewise is sort of in the same family as PSP. And then other Parkinson's disorders, in Parkinson's disease, high doses as high as 2,400 milligrams, so even higher, were eventually shown to be ineffective in slowing the progression of disease. So we need more studies on this drug. Theoretically, it helps with energetics and maybe neuroprotection. But it's a relatively benign supplement. Most people tolerate it really well. Don't be afraid of taking these high doses. It's just the cost in buying the amounts that you need to take it. But if you do take it, I would recommend taking these higher doses for it to be really effective. Okay.
Thank you. Okay, let's see. A question for Alex or anybody, but I think it's directed for you, Alex. This person shared that their mother is on a pureed diet with thin liquids, and they're finding a lot of differing lists of best and worst foods for the puree diet. There doesn't really seem to be great standardization across those kind of lists, and they're wondering what recommendations you might have around that.
This is tricky, not just for you, but for any patient with dysphagia, because standards kind of universally are different. And so a couple years ago, I think it was actually back in 2017, a group of speech pathologists and dietitians actually came together to create this IDSI framework. You may have heard of it. It's the IDDSI, and it's kind of this standardization so that hospitals and clinics try to make sure that a puree is a puree and not maybe mechanical soft or dental soft or something of the like. So as far as the types of food that can be pureed, I've had patients make purees out of all the normal food that their family is eating, mix it with chicken broth or something, and find a consistency that works for them. I've seen that happen, but I would recommend, like a dysphagia diet cookbook. There are many of them. So if you go on Amazon, you'll see dysphagia cookbooks, kind of like there's pureed diet cookbooks. There's all sorts of things. You can kind of see which one is maybe reviewed highest and just pick that one. But also just knowing sort of what pureed means. If you look at the IDSI sort of system, it's, there's no chewing required. It's not sticky. Hold on. I'm so sorry for the background noise. My children are making noise. It should fall off a spoon in a single spoonful when tilted, but it's coagulated. So it's liquids are not included. It's something, it shouldn't be sticky, but it should be one kind of concealed mass. So the fork drip test is the way to do that. You put it on the fork, you tip it upside down, and if it all falls in one ball back onto the plate, that's technically a puree. If it kind of goes all over the place, not quite. And there's also the spoon tilt test if you didn't want to do the fork. So lots of ways to figure that out, but it is kind of incumbent on the family to figure out what works with your family and your culture, and foods that are approachable and familiar to the person you love, because it's more about just finding the safe consistency of any of those foods.
I did not know that about the consistency and like the test for that. So that's super interesting, Alex. Thank you.
There are tests for all the dietary levels too.
Yeah,
so we could, we could go into that another day.
And that's great to know that there are specifically dysphagia recipe books available. I haven't not looked at those before. So great resource. Thank you. And this kind of brings me to another question that we received both in the chat a little bit and then registration. And this, I'd love to hear from maybe all three of you about this. And it's a loaded one, which is feeding tube placement. So if you all could tell us more about considerations for that, or Matt, as you called it, enteral nutrition, including elaborating on the burden of eating, the benefits of feeding tube placement, when is the right time to consider this? And someone also wrote to us about more of the stigma of making that decision, sort of the emotional implications and misconceptions that sometimes surround feeding tubes. This is a question we get a lot from our community members. So would love to hear from all three of you. Dr. McFarland, do you want to start? Or anybody? Sure.
I mean, anybody can start. This can come from the speech pathologist, come from me actually, and the patients, but it's it's a complicated issue. We could probably spend a long time on it, really. But it comes up really when patients are really starting to have a lot of difficulty swallowing. The other issue can be just how long it takes to eat a meal. And I have conversations with patients that it's not just the swallow part, it's just that they have to chew, and how long it takes. It may take 2 hours sometimes to eat an entire meal. And so eating becomes such a chore, and the weight starts to drop, and nutrition drops as well. That's where the concern comes in. And for me and our patients, really, we have discussions about this is more of a quality of life rather than, and sometimes it's a need for nutrition, but ultimately it becomes down to quality of life, and it is a personal decision. All of these diseases are devastating. We don't have a cure, and decisions of what you want to do with your body. Feeding tubes are invasive. You need to have a surgery, outpatient or inpatient, to place a tube in the stomach. So not everybody wants that. It is an artificial means of accessing the stomach. And there are lots of considerations for that. And I think first and foremost is that something you want? Have you ever talked about it? Have you ever considered it? And then the question is it time for that? And that's a question of, Are you choking, aspirating frequently? Are you losing weight? Is feeding becoming a huge a bear for you? You just can't manage it any longer, and you're not able to get enough nutrition. So all those things that come together, and I think it really takes a team, and not just me bringing up the discussion, but also our speech pathologist, and then the dietitian comes in at once the feeding starts. And we have this discussion actually that there are a lot of misconceptions about it. Just because I have a feeding tube, it means I can't eat anymore. Is it going to prevent me from aspirating? The answers are kind of yes, maybe, but so I kind of bring up the question, like, number one, there's some misconceptions. You can eat. It's just you still have your mouth. You can still eat with a feeding tube, but there's a risk for aspirating. And so what you eat is more for pleasure than nutrition. That's something that also you can have discussions with the speech pathologist about. And then there are other things you just talk about in terms of the aspiration risk. People can still reflux. And if you eat orally, that still can be aspirated as well. So those are considerations. So I think, Alex, you can talk more, I think, about your experience with this and discussing with patients. I think it's really critical to have everybody on the team weigh in here on this. There's no simple answer.
I think what you said is actually right in line with what I would say too. My first concern is always your safety as far as what you're swallowing and how you're swallowing it. So that's why we do that video X-ray, the modified barium swallow test, so that we can actually objectively determine, okay, is any material going towards the lungs instead of towards the stomach? When material goes towards the lungs, especially what we aspirate has bacteria, that's where we start to get concerned about things like pneumonia and respiratory infections, which we, want to avoid at all costs. So, oral hygiene is going to be big as far as my consideration for, is it time for a PEG tube? But I echo what Dr. McFarland said, which is, I want to know how long it's taking you to eat a meal. If the burden of eating and drinking to stay hydrated and comfortable and like your body functioning in the best way it can, if that burden is getting really high, then I think it's time for us to consider a feeding tube. Again, it doesn't mean that you can't eat orally. You can. Our job is to find what can you eat most safely while you have the feeding tube. And again, if you choose not to use it, you can just flush it with water to keep it clean and open, and keep you hydrated, and never use it if you didn't want to. But it's kind of it's designed to make you more comfortable and to reduce the burden. Other than that, I think it is that personal choice. I've had patients say, well, that's not for me. That's existing. That's not living. I want to be able to eat, and I will support whatever decision a patient makes. I will say though, at the end of, as your swallowing severity is progressing, for most patients who choose not to get a feeding tube, what I hear is, I feel like I'm drowning in my own saliva. I can't manage it. And it's very uncomfortable. And I'm not able to eat. My weight, I'm dropping like crazy. And so there's pros and cons to both. Our job is to present you with the facts and then hope that we give you the autonomy to make those choices to be most comfortable, whatever is going to make you most comfortable.
Yeah, I would make one last comment, just really that I feel like if your physician hasn't talked to you about some of these are what we call part of the advanced directives and part of wishes. With all of these diseases, being able to communicate your wishes to someone who, either a loved one or a significant other or a friend who you trust, to be able to speak for you if you're unable to kind of voice your wishes. It's important to kind of press your doc, make them bring these points up, take some time, if you have to set aside another appointment to ask these questions. The worst case scenarios I hear are where I get a phone call late in the afternoon at 5:00, patient's been admitted, they're in the hospital, and they've got a total stranger physician walking in the room, and they've told the family member that they need to have a feeding tube right now, and they don't know what to do, and it's never been discussed. And so then it becomes kind of an emergent situation, and it can be really fraught with a lot of emotional difficulty. So I encourage people to it's a hard question. I encourage people to talk to everybody in the team, not just me, but our physicians, but talk to people about these things. To bring it up. It's an uncomfortable conversation, but it's so worth it to have that conversation.
Absolutely. Just want to kind of mirror what Dr. Brandimore and Dr. McFarland said. As you heard in my talk, this is one of the things that I see that improves the quality of life of our patients so dramatically. If you can have that conversation early, if you're only starting to lose weight and, there may be some moderate swallowing concerns. It's nothing that you have to be super worried about yet, but maybe you should start thinking about this for if the time comes. I might recommend you think of a PEG tube or G tube as a tool. You're still you. You're just using this tool to ensure that you are getting all of the nutrition that you need. As Dr. McFarland said, you can still eat by mouth potentially. This just frees you up to do so much more. If you're spending so many hours eating and you're worrying about choking, let's just take that out of the picture. Let's have the PEG tube or the G tube ready for you. You can use it for when you need it, maybe avoid it when you don't want to use it, but it's not something that defines you in any way, shape, or form. It's just a tool.
That's a great way of thinking about it, Matt. Thank you. And thank all three of you. Thank you. And just to add, my 2 cents to this too, and this is just my experience, and I don't, others might have found different situations, but I'll say that from, my 10 years plus in this field, all of my patients and families who chose not to get a feeding tube placed, I've never had one of them say that they regretted it for the reasons that they chose not to get it, not to pursue that. And for all of my patients and families who did choose to pursue it, I've never had one of them say that they regretted it because for the same reason. They had reasons why they chose to pursue it. And so it's important to make an informed decision, an educated decision, one that's supported by your healthcare team. Use all these tools at your disposal. And at the end of the day, be confident in, only you know what is right for you and your family member. And it's okay to stick to that and, be confident in that decision. A question that I'm going to ask myself, I'm part of the panel too, because I spoke, so it's sort of odd to ask this to myself, but I'd also love to hear other thoughts. And I'm asking this because this comes up a lot. And there's not a good answer. Someone during registration submitted the question, do you have any information on potentially receiving financial assistance to keep our father in the home? And I don't have a straightforward answer to this. It's a really tough one. The truth is that much of the time, options for financial assistance are pretty limited, unfortunately. If I or any other social worker or any other clinician ever knew about or knows about a special source of funds for things, we will tell you, I promise. Like, none of us are holding back that kind of information. I would say that if you live in the United States, I would start by seeing if you qualify for any programs under Medicaid. That's going to be different, county by county, state by state, if you're in the US or in a different country, because every country and area has really different setups and resources for financial and healthcare and long-term care supports. I will also add that sometimes I'll see in senior centers or departments on aging or area agencies on aging, these sort of different aging focused resources and communities, or sometimes also state-run independent living services. They'll have different financial or care assistance. It might look like in-home aid programs or no cost or sliding scale programs to help renovate the home environment for aging in place. So it's worth researching those resources in your area too. And then also if you or your partner is a veteran, depending on your connection through the veterans healthcare system, your veterans benefits, they can sometimes include financial assistance or other programs to help with care in the home. At CurePSP also, and you heard, I think I mentioned this in my presentation that I gave earlier, we have the Quality of Life Respite Grant Program, where we are able to provide 60 hours of professional in-home care to families living with PSP, CVD, or MSA. It is, there's a number of sort of eligibility considerations that we look at with that. We're getting more applications than ever. Applications are looked at on a quarterly basis. We actually just ended today, one of our quarters. So maybe, if you're interested, look at that for the next quarter and apply if that fits for your family. But that is a very unique program that we are very fortunate and proud to offer here at CurePSP. And then one more thought that I had with that question too is it can be really helpful if you have access to this financially and in your area to work with an elder law attorney to help with long-term care planning, asset protection, and exploring programs that you might qualify for when planning ahead for care in the home or in a facility. Would anyone else on our wonderful panel like to add to any of that regarding keeping someone in the home and financial assistance? Advice that you might give to folks when they ask this question?
I think you covered it.
Yeah, you really rely on our social worker here. I know there are grants. You can look online. CurePSP is a good place to start. They can point you directions, but your local social worker can try to get you. There are like elder affairs in various states might help. There are grants for assistance that you can look for. I don't know how much they actually provide in terms of grants for, just for care, maybe food, maybe, some assistance for planning, needs in the house, but those are things to actually look at. I know people turn to their church. I really like the fact that you mentioned the VA. A lot of our patients are veterans, and I think the VA does cover Parkinson disorders, not just Parkinson's disease, are often under the rubric of disorders that can be caused by different various agents. Agent Orange is the biggest one, I think. So that's can give you some coverage potentially there. So.
Thank you. And that's actually a segue to another question that I had for you, going in a different direction now to, what can cause these diseases, which I know we're still trying to figure out. It's very complicated, but one person in particular wrote, "My dad is a veteran who was exposed to Agent Orange. Agent Orange has been linked to Parkinson's disease. Is there a correlation to PSP or the other atypical Parkinsonian syndromes?"
Well, I can quickly answer that. We don't know for PSP specifically, but Agent Orange has been linked to pretty much the whole host of different neurological disorders, many of them which are degenerative. It used to be just Parkinson's disease, but the Parkinsonisms or Parkinson disorders are now covered under the Agent Orange. So if you've been exposed to Agent Orange in particular, the other ones like Kappa June exposure and other things are a little bit trickier. But your physician might be able to write a letter stating it's more likely than not that your exposure may contribute to your disease. Now, I'm not sure whether that will always fly, but that's something that you can ask and see how it works for you. Environmental toxins have been covered and been examined. Unfortunately, with the rarity of these disorders, atypical disorders, compared to Parkinson's, we're talking over 1 million people affected, and we're only talking about 10 to 20,000 for each, and probably even less for cortical basal. So doing what are called epidemiological studies, which require thousands of patients, is really hard to do. There are limited environmental studies in these rare atypical Parkinson disorders, unfortunately. So we know very little. We need more studies. But some attempts have been made, and nothing specifically has been linked to these specific disorders yet.
Sort of related, not so much environmental, but another question that we've received are there links between the Parkinsonian syndromes and other medical conditions, like this person specified autism, and we also have gotten questions around vascular disease.
So there's not a link with autism, but many patients can, so these are diseases of aging, and so as we get older, you can have multiple different disorders. We as physicians always like to use, this rule of trying to put everything under the same roof, okay? But people do have different disorders, and different pathologies do co-occur in patients. So you can have Parkinson's disease and Alzheimer's disease. Same way you can have Alzheimer's and vascular or strokes, and many patients with Alzheimer's have vascular. So the same thing actually occurs in these atypical disorders too. So there are vascular forms of PSP, or the combination of both the degenerative disease and vascular burden. And at death or at autopsy, we frequently see co-pathologies found. So it can get really confusing when you get your loved one's path report back and it says, presence of PSP, Alzheimer's disease, and Lewy body in some cases. And you're like, oh, what was the actual diagnosis? So that's really confusing. So you need to go back to your physician. But sometimes these co-pathologies, some of them are just minuscule or minor. But in some cases, we do see people who have multiple different things going on, including vascular. So it's just a matter of aging and multiple things going along. But I don't know if there's a particular association between PSP or some of these other ones specifically with that or other degenerative disorders. Okay.
Great. Okay, great. Thank you. And just a quick time check. We have 9 minutes left in our panel discussion here. I'm trying to get through as many questions as I can. One that just came through the chat a little bit ago, and I'm very curious to hear all three of your perspectives on this from different disciplines. They shared, we live in a tiny town, and my wife, who is in her 3rd or 4th year with PSP, finds it too taxing to get to her neurologist. Is a Zoom type conference sufficient? So, at this point, 3 years into the pandemic, we have all thought lots about the benefits of accessing care through telemedicine and drawbacks through that too. And I'm curious to hear from the three of you about that for these diseases, because they have such a good point, right? Some people drive hours or fly to get to these especially specialty care centers.
Yeah. I'll bring up one. I will actually say yes, no. So the only reason I say no, I think an initial evaluation with a Parkinson's patient in person really is highly suggested. It's not an absolute, of course, but there are some things that neurologists cannot assess through a video. I can't assess stiffness or rigidity in particular, or how your medications might be helping you in terms of, pain or stiffness. So that's hard to really assess physically. There are technical limitations to the video that always happen. But that said, I follow a lot of patients virtually. And I do think for patients after they've been evaluated at least once physically that we can do follow-ups. We have people who come for 3 to 6 hours away and regularly do virtual visits, and that is extremely useful. So I'm totally for it. So.
That's pretty much what I was going to say too. I think you have to have that baseline swallow and speech eval so we can hear nuances in your speech subsystems and also, visually evaluate the safety of your swallowing mechanism. But after that, virtual therapy tends to work pretty effectively, and it reduces burden on patients. So I'm for it.
Same with nutrition as well. Thankfully, if you're able to see a dietitian over Zoom, it sounds like, can do our initial assessments a little easier. If you were in person, I'd be able to assess your muscle stores, your fat stores. And while that's great to have, it might not be extremely necessary. So seeing a dietitian over Zoom, if you can find one, they can very, very effectively counsel you over Zoom.
Yeah. I would have one last thing for folks so beyond Florida, but just keep in mind that there are different rules for doing telemedicine in different states that some physicians cannot, Florida specifically doesn't share, licensure between different states. So, going outside the state, there are some limitations to what physicians can do. So your state may be different than my state, other states. So talk to your physician whether they're able to do it. If you live in two different places, that should be okay, but you likely have to have a home base. Okay. But do talk to folks. But just realize that physicians can't do televisits in every state. Okay. Currently.
Yeah. Yeah. Good point. Okay. Oh, I don't know what question to ask next. How about, because this is also kind of a big one, and I'd love to hear multiple perspectives on this, how to navigate moving to palliative and hospice care. And I'd love to start with that, if that's okay, just to share, because a lot of times these terms are used interchangeably. There's a lot of confusion around them. So I always like to clarify that palliative care, the way that I always understand it, palliative care is a model of care that is focused on easing the burden of symptoms and supporting a person's comfort and dignity while living with a serious and chronic and oftentimes progressive disease. This type of care does, or I should say at least should, start at day one when it comes to PSP, CBD, and MSA. From your neurologist, from your rehab therapist, from the rest of your medical team. It's really how we're approaching someone's care, keeping them as comfortable, minimizing the burden of those symptoms as long as possible. But there might come a point in your care when you want to bring in an outside palliative care perspective, just to offer additional guidance or, on symptom management, on advanced care planning. So I always recommend asking your neurologist if a palliative care specialist is available in their clinic or in neurology, or in the medical center, or maybe in a community-based agency. You can have palliative care concurrent with other forms of treatment like rehab and Botox, things like that. Hospice is where it's a little bit different. Hospice is applied, it's the same model of care, palliative, but it's really applied in the US to people who are thought to have 6 months or less to live, which can be very difficult to define with these diseases. And that is a time frame that Medicare assigned way back when, because they needed to figure out how would someone be eligible for this or not. And I'll say in Canada, I learned that hospice is based on need rather than on number of months that someone is thought have left to live. In hospice in these diseases, we really view it as a next natural step to the palliative care approach. But there can be a lot of confusion around that term, around what it offers. There's stigma around it. So it's really helpful to understand what hospice can offer early. Have this as part of your advanced care directives and conversations with your neurologist and the rest of your team. I'd love to talk about it more, but being mindful of our time, I do want to say that we have a fact sheet on palliative and hospice care, which can be found on the educational page on our website. And in the last 2 minutes, would anybody else like to add to the answer to that question?
Sure. I think that was great. I know there's a stigma when people hear the words palliative, and so there's some movement away, but really it boils down to supportive care for folks. And I totally agree that it should begin early. Even at the first visit, one can talk about things like, what are your expectations about the disease? What do you know? What are your thoughts about, thinking about into life? People should have advanced directives can be brought up early. So it can be a stage thing, and bring it up early can really make it a lot easier, but it is a supportive approach. And sometimes we think about it, another way I think about it is more of when it comes to when quality of life becomes more important than quantity. Is also one way to think about it as well. And having a loved one home, and not in the hospital in an ICU, all the time, having, rushing to the hospital all the time. That is kind of about quantity, sustaining life rather than the quality of life. And so having those discussions early on is important. And so palliative is a really broad term, but it really is supportive, and hospice is only one part of that. And the definition of hospice is kind of broader these days. I agree that 6 month, it's a number we use here in the States, but we often have patients on hospice care for much longer. And one thing I encourage folks is, just it can be started early. And I think, unfortunately, in the U.S., because of the stigma, all too often I see it happen too late in the very end. And family members said, "Gosh, I wish I had that support earlier on." So have the conversation is all I would encourage you to have. So.
Any other thoughts on that from other discipline perspectives? Okay, well, we are at time for this panel. I want to thank all three of you once again for contributing your expertise and your time and your energy to this, with your great presentations and taking the time to answer people's questions. So thank you all. Thank you. Any final words from our three guests today?
I appreciate you guys having us, and it's been an honor to participate. I wish you all the best, and know that we are here to help you, and would love to field your questions as they come up.
Happy to be a resource for anyone who needs.
Yeah, thank you all for putting this together, and we're available to you guys if you have other questions. Thanks so much.
Appreciate it. Thank you all for the collaboration.